Okay, so last lecture of the heart. Here we go. Um, what I think we're going to do for the rest of the week is we will work on review for the whole chapter. We'll work through it. We'll do Zoom the next however many days. We'll have a test on Friday. Um, so tomorrow and Thursday, we'll probably try to do Zoom at about 12:30, somewhere around there, and that way we can answer questions. We can go over some review sheets. I'll get those sent out today as well. Anyway, yeah. So let me see what we got here. 4 people. Okay, so we're gonna finish up the disorders. Okay, and then we can go back and review a little bit here. But let's see. We finished up with these few here with plaquing of the arteries, arteriosclerosis, atherosclerosis, whatever, where we talked about you have this fatty deposit in the vessel that narrows down the amount of blood. It makes the pipes smaller, or like a plug, whatever. And so, if we remember back to when we talked about the coronary arteries, we talked about how some of them were plugged up and all that kind of stuff. We saw how they put a stent in there and very carefully put a stent in there and expanded it and allowed more blood flow to go through. The danger with this stuff here is if you go in there and you can't just roto-rooter it out, you can't just go through there and be rough with this, because if all of a sudden some of this chunk breaks off, now you got a floater. And then, we talked about how the vessels tend to be like a tree. The further out the branch you go, eventually what's going to happen is that chunk is going to be big enough to block off a vessel. And then when it blocks that vessel off, whatever's distal to that, whatever's farther away from that, whatever is being plugged, that's going to suffer because it's going to be starved of blood. So whether that be in your lung, whether that would be in your brain, whether that would be in your anywhere, that's the issue. In your heart, for that matter. Um, anyway, that is what. So that's the danger with that arteriosclerosis. So heart catheterizations, when they take a little thing, a balloon up in there, and they try to get things opened up, the danger is having that a little piece break off. That happened to my grandfather. He had a heart catheterization. The next day or later on that day, he had a stroke, major stroke, and regardless. So that's the danger. Okay, so that's arteriosclerosis. The cardiac tamponade is the compression of the heart due to the fluid or blood in the pericardial cavity. All right, so this is kind of a good review for us to talk about not plurals, coverings, right? So we have the visceral pericardium, which is on the heart itself. We have the parietal pericardium, which lines the cavity, and then we have that space that is generally has some serous fluid in there. Well, if we have an increase of fluid or blood or whatever reason that would be, when we start to increase that, that's going to affect how well the heart is able to contract and to relax. Okay, because if you increase the pressure. So, compression of the heart due to fluid or blood in pericardial cavity. The pulmonary hypertension, right? So increased pressure in the lungs may result in a pulmonary embolism, which is a floater, right? Something that has floated or has caused a clot, and it caused a clot in the lung. All right. A lot of times this happens with lung disorders such as emphysema. When we have in next chapter, when we talk about emphysema and COPD and all this and the lung disorders, we'll see how delicate tissue the lung is. Right. We talked about how thin it was. We have to be able to cross oxygen and carbon dioxide, and so that's an issue there. All right. So. But that's cor pulmonale. Okay. So we looked at that. We looked at this. Da da da. And so now when we get into this, all right, so heart palpitations, right? They're usually strong, fast, and irregular heartbeat. All right, I think there's times when If you've had ever where you feel like your heart's kind of doing weird things, probably was not heart palpitations, but when your heart is beating strong and fast and it just doesn't feel right, a lot of times they'll say that they had heart palpitations. All right. Now, when we talked about the valves, right? When we talked about um, our AV valves, so let me get back up here, right? So our AV valves here, our AV valves, right? They are designed to only allow blood flow in one direction, right? We have the filling, it goes through passively while everything's relaxed. Once this starts to contract, the pressure actually shuts those valves, right? And this pressure builds so strong to where it eventually will eject blood out of the semilunar valves into either the pulmonary trunk or the aorta. Okay. Now, the pressure can be pretty great here, right? And so we don't want these valves, the pressure to go so high that it takes these valves and goes and pushes them the other way, so they look like they've blown back up into the thing, right? And that is part of the chordae tendineae and the papillary muscles, right? So when this wall contracts, that pressure is going to close that. That chordae tendineae is going to hold that valve, right? And then when the pressure gets higher, these papillary muscles will actually contract a little bit, holding that valve closed so that it doesn't prolapse, meaning it doesn't backflow. The pressure doesn't get so high and that it blows the valve that way. Does that make sense? So what that next one that we talked about all the way down here, we talked about mitral valve prolapse, right? It's an incompetent valve flap on the mitral valve allowing backflow. All right, so now for whatever reason, this valve is damaged, whether it's chordae tendineae, whether it's something that's ripped away from the valve itself. So now what we have is we have a prolapse, which means every time this ventricle contracts and the pressure goes high, that blows that valve back that way, and now we have blood not only going into the aorta but also back up into the atrium. Okay, which means less blood is going to fill the atrium from the lungs, which means there could be backup of stuff in the lungs. The other issue is that you'll get less blood shot into the aorta, which means you're not going to get enough blood delivered to the aorta. All right, and so then this thing's going to have to work harder because it's pumping some of the same blood twice. All right, anyway. But regardless, mitral valve prolapse means that valve is not being one way. It is allowing blood to blow backflow into that left atrium. Okay. All right. So anytime the myocarditis, right? So muscle heart inflammation. Muscle heart inflammation. Okay? Inflammation of heart muscle, right? That's what that is. It can be caused by an infection elsewhere in the body, traveling to the heart, right? So a strep infection or whatever. You know, they talk about not having dental work done if you have heart issues and blah, blah, blah. This is kind of what they're worrying about. They don't want you to get an infection of the heart muscle. Okay, so they call that myocarditis. Okay, it's all in the name. Muscle heart inflammation or heart muscle inflammation. Okay, inflammation of heart muscle. Okay, all right. Let's see. This looks like mitral valve prolapse. Okay, so let me just make this bigger. All right, so when we deal with this, if you look here, so we're here at the mitral valve. Number 2, normal open, right? So here we are when we have a normal during that mid to late diastole, right? Relaxation. 70% of that atrial blood is going to go into the ventricle. It doesn't have to be actively pumped, right? Then we have the third here where we start to have the ventricular contraction, just building pressure, and that generally closes the valve. Well, here we go. Now we have that prolapse where we have a valve that is not closing the way that it should. Do we see that? Okay, and so when that thing really contracts, some of that valve may be closed, but it's not completely closed, and so that's going to allow blood to not only go shoot out the aorta or aortic valve, but also, or the pulmonary valve, but the aortic, sorry, this is the mitral valve, but it's also going to allow blood to shoot through that valve as well and backflow into that left atrium. Okay, that's mitral valve prolapse. Okay, and we know it's on the left side of the heart because it's the mitral valve. Let's see what this says. And this looks like probably myocarditis, where we start to see infection of the heart in the heart muscle itself. Okay, let me get this down a little bit more. Okay, okay, okay. So what's that say there? It says prolapse mitral valve 1. Yeah, doesn't close properly. Yep. Okay. Okay. Blah 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 blah. Let's go to heart murmurs. All right. Now, some people, I don't know if you've had your sports physical or whatever else, but how many people we got here? Oh, 5 of you. Wow, 50%. I'm doing well. Some people have heart murmurs, okay? And remember we talked about the closing of the valves, and we had that whole sound of lub-dub, 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 okay? What we're going to do is when we talk about heart murmurs, it's when we don't hear the lub-dub, or we have an extra sound in there that shouldn't be there. It should just be bump, 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 okay? So when we have sounds that are heard, like blood swooshing or whooshing, indicate of turbulent blood. All right, so that either is going to mean that a valve isn't opening correctly or a valve is not closing correctly. Okay, most of these heart murmurs are no big deal. You hear them in children and young people. So like I said, if you sometimes I've done sports physicals where I've heard these and I've told the parents and they go to their family doctor and they say no big deal, it'll probably grow out of it, and most of them do. All right, it's no big deal. And so whether it's just immature valves, whatever it would be, okay. Now there's some abnormal murmurs, that can be from a hole in the heart, from a heart valve, abnormality, like it's just not correct. The valve is calcified, meaning that it's getting stiff, it's getting hard, and so that valve that should be able to open and close very easily now doesn't because it's all stiff and calcified and whatever. And then also you can get it from endocarditis, right? So we talked about endocarditis, right? So that would be, it can be from inflammation of the inner lining of the heart. Okay, and so a lot of times, what is this? Let me see if we can do this here. Let me see here. So really what we want to do is, we're going to want to understand what a normal heart
When a
sounds
healthy
like.
heart beats, it makes a lub-dub sound. The first heart sound, lub, also known as S1, is caused by the closing of the AV valves after the atria have pumped blood into the ventricles. The second heart sound, dub, or S2, originates from the closing of the aortic and pulmonary valves right after the ventricles have ejected the blood. The time interval between S1 and S2 is when the ventricles contract, called systole. The interval between S2 and the next S1 is when the ventricles relax and are filled with blood, called diastole. Diastole is longer than systole, hence the lub-dub, lub-dub, Lub-dub. Heart sounds are auscultated at 4 different sites on the chest wall, which
Okay, hold on. I'm going to put this link in here. Okay, so let me do this. Let's see if I want to insert. What do I want to do? Let's do insert link. Paste. Okay, so that will allow you to see that, and hopefully that'll get that to you. If not, I'll email it to you. But regardless,
correspond to the locale sensed by turbulent flow of blood. Murmurs are diagnosed based on the time they occur in the cardiac cycle, their changes in intensity over time, and the auscultation site where they are best.
Okay, so when we talk about murmurs, right, when do we hear the whooshing or the swooshing of blood? Is it when the heart is in contraction? Because if it's in contraction, that means it's actively pushing blood somewhere. Then if maybe that valve is not opening all the way, and it's kind of like putting your finger over the end of a hose, right? Normally, it'll just flow out nice. But if that opening is closed down, it's like putting your finger over the end of the hose, which is going to cause that water to rush through, and you know how that sounds when you have your finger over the end of the hose. If it's in diastole, when everything's relaxed and you hear blood whooshing, then chances are that blood is not closing, or that valve is not closing all the way, and blood is slipping back through. Okay, and so that's one of the times when you can try to figure that out with systole or diastole. Then when you start to look at these different points, that can help you determine which valve is being involved. All right, so anyway, that's just a quick
examples of conditions associated with common systolic murmurs include mitral valve regurgitation, when the mitral valve does not close properly.
All right, so this is kind of like mitral valve prolapse. Okay, so they're going to show you, and you're going to listen to what that sounds like. So see what they're saying here? That mitral valve is not closing the way that it should.
And blood surges back to the left atrium during systole. The murmur starts at S1 when the AV valves close and maintains the same intensity for the entire duration of systole.
So you hear that? That is that blood that is going through that AV.
This hollow systolic murmur is best heard at the mitral region, the apex, with radiation to the left axilla. On the other side of the heart, a tricuspid valve regurgitation has similar timing and shape, but is loudest in the tricuspid area, and the sound radiates up along the left sternal border. Aortic valve stenosis. When the aortic valve does not open properly and blood is forced through.
All right, so here we go. We talked about the finger over the end of the thumb, right? We talked about aortic stenosis. Stenosis means something that is smaller, right? It's not allowing that valve to open up all the way, which means the area for the blood to go through is smaller. There's still the same amount of contraction, and so putting a finger over the end of the hose causes the blood to shoot through. So that's what she's explaining here.
Through a narrow opening. The blood flow starts small, rises to a maximum in mid-systole at the peak of ventricular contraction, then attenuates toward the end of systole. This results in a crescendo-decrescendo, or a diamond-shaped murmur, which starts a short moment after S1. It is often preceded by an ejection click caused by the opening of the stenotic valve. Aortic stenosis murmur is loudest in the aortic area, and the sound radiates to the carotid arteries in the neck following the direction of blood flow. Again, on the other side of the heart, a pulmonic stenosis has the same characteristics, but is best heard in the pulmonic area and does not radiate to the neck. Other conditions that cause audible systolic murmurs include ventricular septal defect and mitral valve prolapse. An example of diastolic murmurs is aortic valve regurgitation. This is when the aortic valve does not close properly.
Okay, so aortic valve regurgitation. So we have it's not stenosed, it's not whatever. This thing, the ventricles, the left ventricle will contract. It'll shoot blood up through. The problem is this valve will not close and allows blood to fall back into the ventricle.
Resulting in blood flowing back to the left ventricle during diastole, the filling
there?
phase. As the blood flows in the reverse direction, the murmur is best heard not in the aortic area but rather along the left sternal border. It peaks at the beginning of diastole when the pressure difference is highest, then rapidly decreases as the equilibrium is reached. Other common diastolic murmurs are associated with pulmonic regurgitation, mitral stenosis, and tricuspid stenosis. Thank you for watching.
Okay, so that is a good video right there. That's a good video for you to understand murmurs, okay? And I'll put that link on there. Hopefully that'll update when you load it again next time. It should always load and change, but if not, I will send that out to you. So pericarditis, swelling and inflammation of the thin sac surrounding the heart, right? So like the parietal pericardium, right? That outside, or the pericardi, all right, so let's go all the way back to the beginning. Pericardium. A double serous lemma visceral pericardium is right on the surface of the heart. So now what we're talking about is, we saw that endocarditis, which is the inner layer of the heart. We talked about the space between the heart, like cardiac tamponade, right? The space of it. And now we're talking about the layer, the lining, right on the layer of the heart itself. Okay, you can get swelling and inflammation of that thin layer on the outside of the heart. Okay, a lot of times you've heard things like this: angina, right? It's a type of chest pain caused by a reduced blood flow to the heart. So when people have angina, a lot of times that is a indicator that they probably have some clogged arteries, right? They probably have atherosclerosis, arteriosclerosis, which is cut down on the amount of blood that that vessel can deliver, like, oh, he's 70% blocked, oh, he's 95% blocked, whatever else. And what you do is what people tend to find is that they tend to get this when they are exerting themselves, walking up steps. They're out working in the yard. They decided to exercise. They're doing whatever. And anyway, what's happened is their heart is working harder, which means it needs more blood. And since those vessels are blocked off, it can't get the amount of blood that it needs. And all of a sudden, now you're starting to get chest pain because all those muscle cells are needing oxygenated blood and they're not getting them. All right, and so this angina is an indicator that you probably have some vessels that are blocked and you're not getting the amount of blood that needs to be delivered to the heart. Okay? Now, this is a precursor. This can be one of those things that leads to and points to a possible one of these, a myocardial infarction. Okay? It's a heart attack. It's a blockage of blood flow to the heart muscle. Okay, so we talked about ischemic death of tissue when you do not get blood, right? We talked about cardiovascular accidents, right, where we talked about clots will block a vessel and then starve that area of blood. Same thing here. Okay, if we have a blockage of blood flow, whether that be the vessel is just completely blocks itself off due to atherosclerosis, or whether you got a little floater that broke off from somewhere else, another piece of atherosclerosis, and then it hit an area of 95% blockage and just blocks it off all the way, that is what a heart attack is. You have a blockage of the blood flow to the heart muscle. Okay. And the issue is that we want that fixed as quickly as possible, because the longer that you starve this muscle of blood, the more likely is you get permanent damage to the muscle, meaning the muscle tissue dies. When the muscle tissue dies, it does not work anymore. And if you get too much of the heart muscle that doesn't work anymore, then that means the heart doesn't pump effectively, which means that the heart doesn't deliver oxygen effectively, which means you're dead meat. Okay? All right, so then we talked about incompetent valves. We talked in that video, it showed, we didn't talk about it yet. We talked about mitral valve prolapse. Anyway, regardless, these valves aren't sealing things off. They're leaky. Okay? It allows blood to leak backwards, right? All these valves in the heart are one way, whether it's from atria to ventricle, or ventricle to pulmonary trunk, or ventricle to aorta. They are one way. So if they're incompetent, if they're not doing their job, then that means they're leaky. And that's going to allow blood to go backwards, which means we have to pump it again, which means the heart has to work harder. It's not as efficient. Okay, and then you start making certain parts of the heart work harder. That means the muscle gets bigger, which means the oxygen demand gets bigger, which means if you have blocked off vessels, that means you're going to more quickly, starve the. Anyway, okay, you get my point. Okay. So then we have fibrillation. Fibrillation. Oh, let's not do that. Bring that back here. Fibrillation. Fibrillation. Gosh, I can't talk. All right. So we have atrial and we have ventricular. Okay. We have irregular and uncontrolled contractions. Right. And so now we're kind of in freakout mode. Right. That electrical system is all jacked up, and the atrias are just going nuts. They're not. There's no timing to it. They're just contracting, and freaking out. Okay, and they call that AFib. Okay, which people have that, and that is not as a big a deal as over here, right? When you're in ventricular fibrillation, right, it's a regular uncontrolled contraction, just like the atria, but normally we see this in cardiac arrest. When people flop over and they're done, right, and they just pass out on the floor and they hit the floor. This is when you use a defibrillator, right? You got the ones in your church or at school, right? You bring them out. They look like a battery pack, like you're going to jump your car. And you stick them on there and you boom, and you shock the heart. And what you're doing is you're trying to shock the heart back into rhythm. Lub-dub, lub-dub, lub-dub. That's what you're trying to do. But when you have ventricular fibrillation, you are talking about that thing is just spasming. And so it can't fill, it's not pumping well, it's not pumping effectively, and so that's a problem, right? Now you're not delivering blood, and you're not delivering blood to the body, you're not delivering blood to the brain, you're not delivering blood to the heart, you're not delivering, right? All right, so this is the big deal. People have AFib, people will get pacemakers and things like that to help control that kind of thing. But this one here, you get into ventricular fibrillation. If you do not have a defibrillator around, you are most likely not going to make it. Okay. All right, and that's it. All right, so we will spend the next couple days on Zoom, probably around 12:30. I'll send you an invite as soon as I know the exact time. I'm going to need somebody, Smithers probably, to record it, and that way we'll have it. And then if somebody needs it and missed it, you can get a hold of Michael and he can probably send it to you. Or he can send it to me and I can post it on my YouTube channel thing here. So tomorrow, which is Wednesday, and Thursday, we will Zoom. We will answer questions. I think that I have a review sheet. We haven't done the disorders yet, have we? Probably not. Quiz review sheet, the heart. Let me see what this is. Ooh, yeah, this is a good one. Yeah, yep. I don't think we did this one already, did we? No, we have not. Okay. Anyway, I'll get some stuff set out to you. You guys can get some points earned. Oops. And we'll go from there. And what does this look like here? Ooh, what did I do? What did I do? Oh, here we go. All right. Does anybody have any questions? Uh, so tell everybody. I'll try to make sure that everybody is. We want to get this stuff done. We want to get. I want to make sure that you are prepared for the quiz. So, uh, if again, if you are unsure of something, you don't understand the flow, you don't understand the electrical portion, you don't understand something, ask the question because chances are somebody else has that question as well. All right. I'm going to send out some of these sheets. You guys can start to work on them. They'll be 10 points apiece, and then we'll get into doing the test here, okay, at the end of the week. So we'll Zoom tomorrow and Thursday, and we'll go from there. All right, guys. I hope you're having a good break, and we will see you tomorrow with your questions, and we'll go over some of these sheets. All right, I'm going to send them out right now. All right. Talk to you later.